Hello, good afternoon, and thank you, Chairperson, for your kind introductions. And a very good afternoon to all of you, and greetings all the way from Singapore. It is my great delight to participate at the Philippine College of Hematology and Transfusion Medicine's SysMed Symposium virtually. I would like to thank the organizers, SysMed, for inviting me to speak on the subject of platelet aggregations. Although I must declare and say that I am not an expert in this topic, but platelet has always been my favorite subjects in hematology. I did spend a few years doing platelet research at the University of Melbourne, using mainly flow cytometry and proteomics too. Of course, for today's topic, we are focusing on practical issues of platelet aggregations assays at the clinical laboratories. Now, for the topics today, I have divided my talk into two main segments. Firstly, I would like to cover some overview of the platelet function disorders, platelet as functional assays, and the existing ISTH and SSC recommended diagnostic workup. And secondly, I would like to mention of the existing platelet aggregation assay guidelines published by ISTH SSC as well as the British BCSH guideline, and also to mainly also to share our experience in setting up platelet aggregation services in my laboratories. So as we know, platelet functions disorder can be broadly divided into inherited or acquired functional defects. So inherited platelet disorders are a very heterogeneous group of bleeding disorder ranging from mild to more severe cases. Now, it is not my intention in this talk to elaborate on any of the disorder, but other than to say that this is a heterogeneous group and it is relatively rare and with a frequency of about 1 in 10,000 individuals. And the probably more common categories are the acquired platelet function disorder. Now, these are mainly drug-induced or dietary-related or other clinical conditions, comorbidity such as uremia, liver cirrhosis, some neoplasm, which causes platelet dysfunction. And this may be a transient disorder, and when the underlying clinical condition is resolved, typically the platelet function will resume normal function. Now, for the purpose of today's talk, I will only mainly talking about platelet aggregation studies on the inherited platelet disorders. Now, regardless whether it is a inherited or acquired disorder, typically clinical presentation of platelet-related bleedings can be including mucosal or mucocutaneous bleeding at varying severities. And most of them are actually non-life-threatening bleeding, such as epistaxis and gum bleeding. Here's an example of a study done on 148 patients. And as you can see, most of the patients have some form of mild bleeding, and almost 88% of them have a positive family history with other family members with bleeding diastasis. So now talking about platelet function assays. Again, there are broad categories and many different types of platelet function assays. I have just categorized them based on their methods. The first that we have here is platelet aggregations test, which can be measured by means of light transmission, luminescence absorbance, or impedance assay. And there are also global platelet function tests such as skin bleeding time, PFA, or one of those point of care testing. Flow cytometry has been used mainly in research, but now there are some laboratories are actually starting to implement this in the clinical setting. Molecular diagnostics studies as well as other surrogate markers of platelet aggregation, again, mainly confined to research. Now, this is a survey done in 2014 in more than 200 laboratories worldwide. And we can see that LTA or light transmission aggregometry is the main, still remain to be the most common platelet function assay used, as well as considered to be the gold standard for platelet functional studies. Aggregational properties is directly linked to patients' platelets' ability to form initial platelet plaques. Hence, it is directly correlated to clinical bleeding scenarios. Now, following very closely is the PFA, or the point of care testing of for platelets PFA 100s. This is mainly probably attribute to the fact that it is easy to perform. I will be talking individually each of these tests briefly in the following slides. Now, skin bleeding time has been one of the oldest whole blood kind of approach, in vivo hemostasis approach to test the platelet functions. Now, it is still commonly used in research for animals in the animal tail bleeding studies in the same principle. It is relatively cheap screening test with no sample manipulations, and it assess platelet function in the presence of cellular components such as red blood cells and white blood cells and under a flow conditions. However, this technique requires skilled personnel and also strongly influenced by many variables such as the skin thickness, venous pressures, or the temperature of the surroundings and the temperature of the patients. It is considered an invasive procedure and may leave scars. In our setting, it has been discontinued. But I understand that in some of the laboratory, this is still one of the primary or initial screening tests that probably when performed in the right with the right protocol, it is still very informative and can provide us with very good indications of patients' platelets functionalities. Now, as mentioned earlier, PFA 100 is one of the most popular point of care platelet functional assay that has been used. It is probably exists for more than 25 years and is widely adopted, and in some places it has replaced skin bleeding time. It is similar to skin bleeding time in the sense that it is a whole blood assay that simulates blood flow in vivo, or rather in vivo hemostasis. Now, as shown here in the diagram, there is a aperture that is in the sample cartridge, and the membrane is coated with platelets agonists such as collagen epinephrines or collagen ADP, which activate platelet as the blood flow through or aspirated through this aperture. Now, the time taken for this aperture to occlude is the time called closure time. So in the presence of platelet dysfunction or other abnormalities, the closure time can be prolonged. Now, it is to note is that there is even though it is very simple and easy to perform, it is still have its limitation in the sense it is influenced by hematocrits, a low hematocrit of less than 25% and platelet count of less than 100 tends to affect the results. So if there is that is to say, if there is a quantitative disorder, then likely you will not gain, you will also report a prolonged closure time, which is attributed to the quantitative defect than the qualitative. Now, it's been many in the early time, in the early stages when this PFA was introduced, there was a lot of criticism on the method in the sense it is not sensitive enough, particularly in these studies here, done in 2004. It has shown that the PFA denoted here on epinephrine C, epinephrine, collagen epinephrine, majority of those patients identified with platelet dysfunction actually have normal CT closure time, which is in the green zone here, and also relatively normal ADP. Only 20 about, so in these 43 healthy individuals, compared to the 43 healthy individual as a normal reference. Now, later on, as we characterize this group of disease better, these are actually mild vulnerable disease, which tends to have even normal bleeding time. Hence, the sensitivity of with further studies, majority of the studies reported that it is PFA still remain to be a very good with a very good negative predictive value to exclude severe von Willebrand disease type 3 as well as the von Willebrand disease type 2A. Now, having said that, a positive test does not necessarily mean there is any von Willebrand disease. So hence, the utilization of PFA has been used for as a primary platelet dysfunction analyzer as well as a screening for von Willebrand disease, except that it is non-specific for von Willebrand disease. So the next is the light transmission aggregometry that we will be talking mainly focusing on for today's topic. Now, it is the gold standard in platelet function study. Basically, the method has not changed since about more than 50 years ago when Brian and Von introduced this method for studying the platelet functions. Basically, platelet-rich plasma is being included in this cuvette as shown here, and it is placed between the light source and the photocells. As the plasma is cloudy due to suspension of platelets, and it will always start with very little of light transmissions. Upon addition of agonists, platelets will start to aggregate, and there will be more light will be able to transmit as the sample become clearer. And so with this platelet aggregation, as it happened, the tracing will actually follow to give aggregometer the result tracing, which give in the next schematic diagrams. This is a classic or a typical biphasic aggregation trace that we can get from whatever instruments, aggregation instruments that you are using. Typically, in the resting stage, the platelet will be appearing in the discoid and biconvex shape. As the agonist is added, platelets are activated and with some shape change. As the platelet changes shape and start to form small aggregates, it will start to release its dense granules, and hence it will mark the secondary wave. As the dense granule is released and platelet degranulations happen, the aggregation become irreversible. So this is a classic of primary wave and secondary wave that we typically can see from platelet aggregation studies. Not all the platelet dysfunction can be detected by LTA methods. In these studies, very old studies, about 106 patients that has confirmed abnormal bleeding time were shown to also have a storage pool diseases. Now, out of these 106 patients, only 23% of these patients have normal LTA response to ADP, epinephrine, and collagens. So maybe it's not very clear, but the closed circle here denotes patients with abnormal aggregations. So in other words, if patient only have a platelet pool, storage pool disorder, they could very well have a normal response to ADP, normal LTA response. But only when you measure it with the secretions, then you realize that these are actually have an abnormal secretion patterns, which is why when luminoaggregometry being introduced, it is a great complementary tool to LTA. It enables study of LTA simultaneously with dense granule release assay, particularly the release of ATP. Basically, a panel of agonists similar to LTA will be used to induce the degranulations. In the sample there will be reagent called luciferase that is being mixed with the PRP, and as the agonist added and platelet went into degranulations, ATP that is released will react with luciferase and give out a chemiluminescence, which can be measured by, which can be recorded on the absorbance. So from this tool, it is clearly shows that it is a very important and useful tool for studying patients with platelet granules release disorder or storage pool disorders. Now, the next thing is the flow cytometry. As I mentioned earlier, flow cytometry typically are not used in the clinical practice, but it is have gained popularity because it requires a very small amount of blood. And sometimes with fixations, it even allowed the testing to be delayed and to be done in the batch, as a batch test. Now, they are potentially can be used also to diagnose patients with low platelet counts, because knowing that flow cytometry has the ability to acquire, by changing the acquisition time, we can acquire sufficient number of cellular platelet in this case for characterizations. Now, it measure up regulation of surface markers such as surface receptors such as GP2Bs and or GP1B upon activation, as well as soluble markers such as p-selectin that is being released from platelets. Now, here there is a study about on 61 patients tested by flow cytometry over 3 days using fixed platelets, and almost 84% of them shows a concordance with Lumi aggregometry. That means to say, the patient is diagnosed as abnormal in lumen aggregometry, are also diagnosed as abnormal with flow cytometry. So clearly this is a good news. However, flow cytometry is a static assay, and it does not include any flow of the sample blood flow. So, and it also require expensive instruments and really require experienced staff to perform the test. And most of the time, and most importantly, it actually lacks standardization. Hence, most of the use of flow cytometry is confined to research use. Perhaps the main criticism for this method would be that there is, to my knowledge, there is no direct correlations of flow cytometry expression studies or surface marker expression study that can correlate well with the clinical bleeding condition, which means the clinicians, when you are given expressions of surface markers at certain levels, it is not sure whether there is still clinical validation need to be done, whether what is the threshold for this surface receptor before patients will suffer bleeding problems. So, but nevertheless, there are many applications that has been published with some rather good protocols, and this is one of the example that I find from the literature. And this is similar to our restaucitin induced platelet aggregation methods, where we use flow cytometry as a mean to measure the mixing studies and to differentiate platelet type von Willebrand disease versus type 2B von Willebrand disease. Now, the mixing studies are done by having a labeled von Willebrand factors, and when there is a aggregations or when there is a binding of von Willebrand factor, you will see an increase fluorescence or platelet that is labeled with the fluorescence. So very simply, similar to RIPA, the same principle for patients in this panel A, when there is a when patient is having a platelet type von Willebrand disease, in the sample tube of black and red, where patient plasma, patient's platelets are being used, we can see that even at the low dose restaucitin, in this case is 0.5 milligrams of restaucitin, will induce strong aggregations. So basically, this is to test that because platelet type 1 variant disease is a rare autosomal dominant bleeding disorder, which is um, due to mutations in the GP1B receptors on the platelets, and it increased the affinity for virulent factors. Hence, in the panel A, as I mentioned, there will be even though when a low dose of restosity is being added to the tube, you will get enhanced fluorescence or enhanced binding or aggregations, as you can see in the aggregation panel study in the LTA in the panel B. And similarly, to differentiate from type 2B von Willebrand disease, when the mixing is between patients in the green patients plasma, and as well as the black tubes here represented as patient plasma, there will be increase in numbers of increase in binding of von Willebrand factors. So this way, it is also a potential. There is a potential for using flow cytometry to differentiate between platelet type von Willebrand disease and type 2B. But again, not every laboratory have the expertise to run a flow cytometry type of reaper, but this is certainly possible in laboratory that has good support in flow cytometry. That's the first part of my studies, my talk here. I can take some questions at this juncture. Okay, if without any questions, I will just move on to the next sections of my talk. I will be talking about platelet aggregation assay setup. It is largely with reference to the guidelines provided now. In the early stage, we do not have so many guidelines, so we actually turn to textbook for references. But these days, we have many good guidelines that is available from CLSI guideline, from British BCSH guideline, as well as the ISTH SSC recommendation. So I will just be going through some of the important points that is recommended. And in my slides, those in the bold fonts, boldface, actually generally denotes the consensus, majority consensus, the strong consensus. Now, all these guidelines have a, for the ISTH guideline, they use a rank method where a median score of above 7 means a majority of the laboratory agrees on certain criteria. However, sometimes the median score is above 7, but the range can be still very wide, meaning there are still a wide selections of laboratory that perform different from one lab to another. In the BCSH guideline, it is classified as grades. Grade 1 being very strong evidence and grade 2 weak evidence, and whether it is an observational study, a grade C, or a clinical trial or randomized clinical trial, a grade A. So I will just briefly mention through the guidelines. And also all this will be shared in reference to our own experience. Now, our lab has established the platelet aggregation services since late 1990s, and there is back then there was only a few hematologists will be doing the reporting, simply because the reporting of this require a understanding of complex platelet physiology, and also to interpret the results with the limited panel of tests we can do back then. So we in the laboratory, we try to standardize our methods according to international published guideline. Back then, it's not as readily available, and because it is as mentioned before, platelet dysfunction is a very rare occurrence. So we do not actually receive this test request as often. This means that the staff will actually not get enough practice or learning how to perform the test. So, and also as part of the QC or quality control for the test, we typically require a healthy donors to be run in parallel with patients. So in this aspect for our lab, we have many good staff, many brave donors, but sometimes even the brave donors will run out when we start to request for more and more. So I will just briefly mention it further later. So basically, getting a healthy donor is not as easy, and sometimes we have a healthy donor that responds very well to 3 of the 5 agonists, but does not respond at all to, say, for example, arachidonic acid, probably due to a dietary induced kind of refractory for certain type of agonists. Hence, in our laboratory, we find it challenging to find a perfect donors to run. And if we find one, we usually will try to be nice to the staff, and hopefully every time when there is a request for platelet aggregation, we will invite the staff to be the donors. So in our laboratories, for before you can order this test, typically we require a hematologist consent, and also a thorough patient histories and family history must be evaluated, and typically a full blood count as well as morphology will be ordered before a test can be ordered. So and more importantly, all this information we always request for the information to be passed on to our laboratory. So so generally, by the full blood count, we will know that the platelet count is sufficient for aggregation studies or not. We do not usually run a global screening test. Ever since we retired skin bleeding time, we do not usually run a bleeding time before we accept a platelet aggregation request. However, we do have impedance methods if the clinicians would like to do a quick screening, because the whole blood impedance assays that we use require less sample. So, but then having said that, it is still not very often being requested. So at the same time, we also usually the clinicians will also order some other coagulation tests, such as von Willebrand disease panels. So in our laboratory, the panels will include a factor 8 level activity levels, von Willebrand antigen level, as well as von Willebrand activity assays. So this will help to rule out any von Willebrand disease. And for genetic study, as if required, if our platelet aggregation study is inconclusive, sometimes clinician may decide to send the sample for overseas for further tests. Now, in LTA, typically it is very useful, just a general note, LTA is typically useful for studying subjects with bleeding disorder. It is not typically useful for studying of platelet hyperactivity, okay, which typically require some standardizations. So in our settings, LTA is also not being used, typically used for monitoring antiplatelet therapy, except for in research. Now, by itself, the platelet response to antiplatelet therapies like aspirin or clopidogrel, actually in the literature, there is still not enough clinical trial data to support monitoring of antiplatelet therapy. However, I know that there is some modified platelet indices that has been used for monitoring platelet patients' response to antiplatelet therapy. Some of the clinicians, or especially cardiologists, always like to know whether the dosage given to patients is optimal. So even though we laboratory we will not reject platelet aggregation requests for such purpose, but you will again go through the hematologist. So in platelet aggregation studies, we typically require patient platelet count of more than 100 thousands per microliter, and we will avoid patients with recent transfusion, and also we will check on patients' conditions. Typically, we will avoid patients in ICU because we know that acidosis or alkalosis will actually affect the platelets functions. So this is an old study has shown that when as the pH drop, the activity platelet aggregation property will also drop from this curve A to curve E. Hence, we typically, if sample, if patient is really in ICU, we will actually check for the other tests such as the pH and other related test parameters in order to determine whether patients have any possibility of transient suppressed platelet functions. So in pre-analytics conditions, and patient preparation is probably the most important things to determine that will determine the successful usage of our platelet aggregation studies. Now, in the ISTH guideline, these are the guideline that we are following. Typically, patients are required to have a short rest when they arrive to the clinics. We will not draw the blood immediately. There will be a resting period. And we also would like to ask the patient to refrain from smoking for at least 30 minutes before the blood draw, and to abstain from caffeine, which is usually not very successful, for at least 2 hours before the blood draw. So these are not, as you can see, these are not in bold fonts. It's not a hard and fast rule, but it is good to, it's a recommended, it's a good to have kind of recommendations. And of course, medication history must be taken down, and any non-steroid NSAIDs must be stopped at least 3 days before sampling, and antiplatelet drugs should be stopped at least 10 days before sampling. However, in some scenarios, it will be impossible to stop the medication before the blood is being drawn. In those scenarios, we will note down the type of drugs used, and also it will be taken into account when we interpret the results. Now, fasting is normally not a requirement, but we require patients to avoid a high fat content meal just before the sample draw. This is just to avoid any lipemic sample. Okay, and the blood collection methods, is most, we know that platelets are easily activated through traumatic draw. So venipuncture must be done carefully to minimize these platelet activations, and should avoid venous stasis. If we use tourniquet, the tourniquet must be released once the blood is flowing. In our laboratory, we do accept butterfly cannulae. So provided the flow is continuous and the first few 3 to 4 mils of blood is being discarded. And we use a siliconized glass tube. It can be a 3.2% or 3.8% of sodium citrate, as long as each center is consistent within their center. And we generally will avoid having underfilled tube, but in certain scenario, sometimes we have to, because of difficult veins, we may accept this sample, but it will be noted down in the reports. So in the pre-analytics, another pre-analytics that is very important is how the sample specimen is being transported to the lab. In our laboratory, we require hand delivery of samples, and specimens should be maintained at room temperatures. By room temperature is about average of about close to 25 degrees Celsius. And it is this is taken from the BCSH guideline. So 1B is a strong evidence for keeping the sample at the room temperature. And from observational evidence, the tube must be kept upright and must be kept to preserve the pH, as well as no excessive mixing or agitations. Then sample should be rested before centrifugations, and no more than the testing should be completed no more than 4 hours after sample collections. In the event there is a delay, for example, due to instruments errors, the times, the delay must be noted down in the reports. Just a quick mentions, as we studies to show that as the sample is being left for too long, and if the initial mixing was not done correctly, not done adequately, there will be a starting spontaneous small platelet aggregates may form on prolonged standing. Hence, the studies will no longer be accurate. So the next thing, when the sample arrives to the lab, for blood sample, we generally allowed to rest for at least 15 minutes before centrifugations. And the blood sample must be, as mentioned earlier, remain at room temperature. In our centrifugation, we do 2 spin. The first time low spin, typically at about 200 Gs for about 10 minutes. Now, each laboratory should evaluate the speed of the centrifugation to be used with their own equipment, as well as calibrated according to the speed, the platelet counts, background counts that is achievable with the centrifuge. So for a laboratory, it's about 200 G. Now, platelet whole plasma is then prepared by centrifugation of the whole blood after withdrawing of PRP from the primary tubes, and further centrifugations at a high speed of 1500 G for 15 minutes to obtain the PPP. Now, the sample conditions is very important. So the grossly hemolyzed samples, without every consensus is that grossly hemolyzed sample will affect platelet function and therefore must be discarded. And if the sample tested is lipemic, the final report should indicate that this is so. And for our laboratory, we do check platelet counts of the PRP sample tested. I know some laboratory do not check the platelet counts and maintain a similar level. So for our laboratory, we maintain similar level of platelet counts between patients and controls. And minimally, platelet count should be about more than 150. And it is in the in the guidelines, the median score for this is about 8, but the response is 5 to 9, meaning a large number of laboratory do not agree with this cutoff of 150,000 platelet counts. So, but in our laboratory, we try to maintain it above 150 in order to have enough platelets being measured for the platelet aggregation response. Caution must be taken when interpreting results with abnormal results, especially when the platelet count is low. So in some exceptions, a Glanzmann thrombocythemia, for example, the platelet count is low and there is difficulty in getting sufficient platelet PRP. So we have, in my laboratory, we have done a Glanzmann thrombocythemia before, and unfortunately we are unable to enrich the PRP to the minimum platelet count level. So we have recommended using another methods to confirm this study, namely to use flow cytometry. So for this platelet counts, the issues about adjusting platelet rich plasma. So typically when we enrich or when we do a low spin or sample, we may get a platelet count of PRP that is above 400 or 500,000 per microliter. So there have been different opinions whether we should use the autologous platelet pool plasma to adjust the platelet counts. Now, adjustment of platelet counts with PPP typically will impair the platelet response because while centrifuging the PPP, typically ADP or ATP are released from different cellular components such as red blood cells. And with this ADP in the plasma, it may impair or it may reduce or desensitize platelets to the ADP response. There are several studies that shows that actually there is no significant difference in the maximal aggregation for sample count, platelet counts within 200 to 600,000 per microliter. So with that, some of the laboratory that I know of, they once they enrich the PRP, they do not actually measure the platelet count or to adjust the platelet count with PPP. So each laboratory should decide what is the optimal methods to use. For our laboratory, we do have calibrated the equipment centrifugation speed according to different platelet counts. So if the patient has a platelet count of say 300, we will then use normal platelet standard speed of 250. If the platelet count is actually only below 200, we may use a lower speed in order to acquire final concentration of platelet between 200 to 300. And we typically also use a healthy donors with similar platelet grounds for direct comparisons. Now, a bit more on this adjustment of PRP. I have referred to two of the studies. One studies are using saline versus PPP or platelet pool plasma to adjust the platelet counts. So the platelet counts here, original undiluted platelet count is about 200. The count is about 200. So in the first segment here, there is 1.5 times of dilutions. As you can see, there is no significant difference between with these 20% dilutions with saline or PPP. There is not much of significant difference as the dilution is more. So between 1 in 5, 1 or 2 times dilutions and 2.5 times dilution, naturally the platelet aggregations response reduce because the amount of platelet is actually reduced. So in the saline, there is no suppressive effect. Okay, as we can see here on the second bar here, on the orange bar, you can see the blue bars here representing the PPP adjusted platelet PRP. There is a significant suppression as we increase the amount of proportion of PPP in the mixture. Here, there's another study that is also similarly demonstrated the effect of the inhibitive effect of PPP when it's used to dilute the PRP. And you can see that undiluted platelet counts, say between 400 to 600 over the platelet count is 400 to 668. As the platelet is being diluted to 300 using autologous PPP, we can see that the platelet response LTA has greatly reduced when you stimulate it with ADP. However, when the platelet PRP is stimulated with collagen, there is no noticeable difference between the diluted samples and non-diluted sample. This is to illustrate that the PPP has may have an inhibitory effect because of the ADP release. Now, in some experiments, they have used a pyrase enzyme that will hydrolyze the ADP release during the centrifugation of PPP. And in those experiments, they have successfully proved that using PPP to adjust when you will not demonstrate this kind of inhibitory effects. But that is if the sample is being spun in the presence of a pyrase or some other ADPase hydrolysis. So, however, in our context, we avoid using PPP to adjust platelet counts. And the next very important considerations is the platelet agonist panels. So the 5 platelet agonists that has been mentioned before is the typical initial panels of agonists to use. And in the guideline, it has provided a starting concentrations, ADP at the 2 micromolars. So, and if there is patient has no response, then a higher concentration of ADP should be used. But in our settings, I'll share a bit later, we actually start with higher concentrations of ADP simply because during our evaluation, we realized that more than 50% of our donors do not respond or do not give any optimal response at 2 micromoles. So if we start with these 2 micromoles, chances are we need to repeat the test again to if we gradually increase. So with that setting, we actually start with the higher dose of ATP. For epinephrine and collagen, we follow exactly the guideline, and we will increase the dosage as necessary. Now, just to mention here, there is a very good studies, a multi-center studies to evaluate automated ergometry. It has very useful tips for those who have the similar instruments and to provide a good starting point when you evaluate your own studies. So this is the reference that you can refer to. And other concentrations of arachidonic acid, we use 1 millimoles. And a word of caution is that we tend to avoid high dose of arachidonic acid, especially when we were using chronolog reagents, because of the toxicity of these reagents, and also the fact that higher concentration of arachidonic acid may cause membrane lysis. Hence, as what we can see from flow cytometry, if you use a high concentrations of arachidonic acid, you will increase the debris or the platelet fragments or in the sample. Hence, we typically use 1 millimoles, and we typically can get a response from these 1 millimoles. And the other agents agonists that we use is ristocetin. We start with 1.2 milligram, and if there is a need, we will drop it down to a lower concentration to differentiate the platelet type, von Willebrand disease or von Willebrand disease type 2A. So there are other agonists for extended panels such as TRAP, thrombin receptor activating peptide, or thromboxane A2 mimic. These are more further panel that can be used to study the different platelet signaling pathway. But in our laboratory, we do not use any of these additional agonists. But we potentially can use if there is a research need. So here I shared one of the very old study done in the Middle East, and these studies are referring using particularly of interest because it has using about more than 500 participants, and it studies the differences between Asian. Here, Asians means was referring to Koreans and Philippines populations compared to those who are Koreans and Filipino who stays in the Middle East, compared to Saudis and Westerners as well as Africans. So in these studies, I find it interesting to note is that we can see that there is a difference in the response to ADP, as we can see here in the 2 micromoles of ADP. The Westerner tends to have a higher maximum aggregations compared to Asians. Okay, and also likewise in the arachidonic acid, Westerners tends to have a have a lower response to arachidonic compared to Asians. Now, this is can be same results can be seen in a different manners, and perhaps this is easier to understand. Here is another way to present the results. The reduced platelet aggregations are referring to maximum aggregation that is less than 40%. And so, as we can mention earlier, for Africans, okay, we can see a difference in the response. There are 63% of Africans do not yield a normal response to ristocetin at 1.2 grams compared to Westerners and Asians. So this largely suspected due to the sickle cells that is present in high prevalence among Africans. But however, further study need to confirm that. But basically, what I wanted to illustrate here is that it is important to consider ethnic difference especially if you want to adopt a reference range. As you can see, the Westerners has rather have a different profiles of response to different agonists compared to Asians or other ethnic. So it is important to consider the ethnic differences when establishing reference range, or if you want to adopt a reference range, it is important to validate that reference range. And also, we need to determine the optimal concentration, starting concentration of agonists for the testing. And for reference range establishment, we are also required to record down the demographic data. Okay, for these studies, the demography such as patients, the donors, smoking conditions, and other age, blood groups, and everything are being recorded. And from covariate analysis, all these effect of age, weight, height, and smoking and blood group did not show any statistically significant difference among the different 4 different study groups. However, so in our own establishment of local reference range, these are some of the important practical consideration we should take down. We should note down the status of smoking, for example, in order to analyze the results. So here's my laboratories, our laboratories local reference range using more than 40 donors. And as mentioned earlier, we actually use 10 micromolars as our starting concentrations. Maybe perhaps because of this concentration, we do not see any biphasic response, which characteristically seen with ADP. Epinephrine, we use the guidelines as per guideline, and the rest as well. So these are what are the maximum aggregations response that we get. And in the report, we will note down whether it is reversible or irreversible or monophasic or biphasic kind of response. So there are some other considerations. As mentioned earlier, it is recommended for LTA study to always be studied in parallel to normal donors. However, it is challenging for our lab to always have a healthy donor, and the same healthy donor may have slightly different profiles, aggregation profile, just depending on what the person eat the day before, or so it is a challenge for us. And also, our PRP must be used to set 10%, 0% light transmissions, and PPP as 100%. So this is the conventional methods. Now, if you are using a saline diluted method, then saline diluted PRP should be used to set the background. So, and typically this testing is done at constant temperature at 37 degrees with constant stirring speed. And typically, the volume of the agonist added should not be more than 10% of the sample volume, just to avoid further dilutions. Platelet aggregation should be traced for at least 5 to 10 minutes. So now the rest of a few slides, I'm just sharing with our journeys on using different aggregometry. So earlier on, I mentioned that we have started our platelet aggregation service in the late 1990s. We started off with a very old equipment that has a external graphing graphing mechanism. So it is very important for all of us reminded to make sure there is ink on the paper, and the paper is adjusted accordingly, so that the paper, as the sample is being run, as the aggregation happen, the paper will continue to trace correctly, so there is no blockage and the trace is will not be recorded. And imagine if there is something wrong with the printer, we will have to repeat the test, and typically we do not have enough sample to repeat. So in the very early stage, we have a single channel, and this is a dual channel. I do not have the picture of the single channel equipment. Then we also have a slowly then we improve ourselves to 4 to 8 channels, with 4 channels and 8 channels ergometry. So this has significantly made our life easier because we are able to simultaneously perform all the agonists at the same time, so there is no delay in the testing. So currently, we have finally moved into an integrated platelet aggregation testing platform. We use Sysmex CS 5100 for platelet aggregations, and it has an automated pipetting of reagents, agonists, and aliquoting of PRP. However, the manual methods for preparing PRP and PPP is still remaining, but it is not difficult because once the system is set up, it is basically a walk away kind of scenario. We can actually allow the test to be run on its own versus traditionally with the other instruments. A staff will typically be engaged right at the instruments to observe the aggregations and to add the agonists at the right timing with the right um, mixing. So our lab definitely welcome this new integrated platelet testing methods. The main advantage I would personally feel is that the fact that we require it require less sample volume, because typically we used to request for at least 20 mils of whole blood from patients for testing, and also 20 mils from a healthy donor. So you can imagine why the laboratory staff are growing tired of being a donor, platelet aggregation donors. So in these new methods, we actually require only about 1 mil of PRP. So we can do with just drawing three about 10 mils of whole blood from the patients. And reagent preparation is rather relatively simple, and it is because of longer stabilities, we are able to compare the new uh, reagents with the previous batch. Even with some freezing ability, we are able to do cross log-to-log comparison. And it is indeed less operator dependent, and the standardized pipetting by the equipment has make it easier for us to compare. And as mentioned earlier, is walk away after the setup. However, there is still okay, so the other features such as tracing of traces, it can be easily done, and we don't have the issues of printer no ink and we lost the results, because it's all recorded in the computers, and traces can be retrieved at the end of our testing. And if repeat is needed, there is usually sufficient sample because of the fact that we only require a small sample volume. The so-called less desirable status is, of course, the instruments will be down for at least more than an hour during the testing. Now, so this is because because of that, we actually have an appointment system. So when the platelet aggregations is being ordered for a specific testing day, the equipment will be so-called down, or will be blocked off for this platelet aggregation studies. But there's no big issues because we have backup instruments to perform as well. So, and there is also one potential disadvantage if we have two or more samples to be assayed at the same times. We feel that because of the mechanism, so there might be a prolonged standing of the PRP inside the instruments while waiting for the aliquoting of agonists, because of the limited number of reaction cells that is being used. So these typically, when we are doing it on the manual basis, we are able to manually just take the sample to make sure the PRP has not sedimented and the sample is still homogeneous. And I think with the 20 microliter of reagent that is being added into 160, we can see there are some dilution that is happening. But from our evaluation, we are still able to, with the healthy donor, we are able to get a decent aggregations happening. So of course, I always have a wish list. So if our, I'm just wondering because CS 5100 have multiple wavelength, and I know probably not sure technically if it is possible to have include a luminescence detector to enable platelets aggregation studies to be studied simultaneously as a the simultaneously for platelet secretions. And if that can be done, that will be wonderful. So so here I just want to briefly mention, I know that there have been studies or evaluation of platelets, new indices used for monitoring antiplatelet drugs effect. I have not done this myself personally in our laboratory, but I'm aware that by using, there are different, there are currently some studies or already validated studies for using this APAL score or ADP platelet activity level score, as well as collagen's platelet activity level score. So basically, the principle is that they use threshold concentrations of agonists versus high concentrations of agonists to stimulate patients' platelet who are currently on drugs. So then the difference or the reactivity of patients are being calculated using a special index. And from that index, we can look at the degree of suppressions of platelets after attributing to the effect of antiplatelets. So I think this is an interesting aspect that may helps to, especially cardiologists, to determine the platelet activity reactivity after patients given the drugs, or maybe to check the compliance of patient, whether patient actually are taking the antiplatelet drugs regularly. So, but in our experience, we have not used these methods. So the last part of this talk is on our aggregations result, platelet aggregation results. The reporting format as recommended, we should include the percentage changes, length of lag phase, as well as the maximum or MA, maximum amplitude or percentage aggregations. So in our laboratory, we actually provide the actual tracing for clinicians to review. Hematologists who report the results will not just relying on the percentage of maximum aggregation, but also to look at the shape of the aggregations. So that itself actually will give a lot more qualitative information than just a quantitative results. So in our laboratory, unfortunately, we do not upload our platelet aggregram onto LIS because of just because of storage limitations and other LIS limitations. Now, in our in the survey on this LTA reporting formats, I think majority are including PBF or platelet morphology as well as full blood counts into the final report on the LTA. So in our case, I think we are using as much of indices we can find from our full blood count instruments. We use a XN2 XN series equipment. We are able to see the immature platelet fractions as well as the platelet fluorescence that can be used or reported by the clinicians, because we know that immature platelets or platelet with high fluorescence tends to be more active than the old platelets. So these are the additional information that we provide for our hematologists to help with interpretations of the results. So likewise, morphology is always very important and couldn't be understated. If there is already a remarkable features based on the size of the platelets or the granules, a lot of times the diagnosis can be already being directed or guided in the certain directions. So we include PDF into our platelet aggregations reports. And lastly, in this current context, in today's context, I think is everybody will have to mention about COVID-19 disease. So for myself, platelets and COVID-19 disease, we have not done any platelet reactivity studies on COVID-19 patients, but I am aware of some studies that have using whole blood assays and it is indeed showing that platelets among COVID-19 patients are hyperactive and hyperreactive. So it is important for us to recognize that this the thromboinflammatory events that is happening in patients, especially patient who has recovered, whether the platelet activity is permanently becoming hyperactive or it is transient only during the disease stage. So this is something that we have not studied, and I'm not sure if anyone else have studied in this. But certainly LTA in this can be used for further investigate this platelets among COVID patients. And with that, I will end my talk. And again, thank you for having me here. And this is just a night view of Singapore, and hopefully our borders will open and one day, and that everybody can travel, and you will be most welcome to come to visit. And with that, I will just conclude my talk here. Thank you.
All right, everyone. If you have any questions for Dr. Yip, please send in your questions. We also like to invite Dr. Yip to be live on this platform. Dr. Yip, are you there?
Yes, I am here. Hello. So that
Yes,
was
so
recorded last year. So now we have our border open, but new variants, new rules.
mm, mm.
Okay.
so so we have two questions from Dr. Nareen. Perhaps Dr. Yip, you could address her questions here. So the question here is, the first question is, according to the NASCOLA guidelines, NASCOLA, if I'm not mistaken. So the NASCOLA guidelines, what is the definition of significant deaggregation? And if possible, could you demonstrate some example?
Okay. Am I able to show?
Yep, so I gave you the presenter rights already. Yeah, we can see your screen.
Can see the screen? Yep.
Yeah,
Thanks,
but
Dr.
it's
Nareen,
a
for your
presentation.
questions. I got it this morning. So I have a look. I went to take a look at the NASCOLA, the guidelines, and I guess the question was, is there any quantitative way of determining what is significant the aggregations? So unfortunately, I think for this, we do not, in my laboratory, we do report de-aggregations uh, as a qualitative way of descriptions, but we do not report the percentage of de-aggregations. Now, I went into this morning, I went in to do a bit of my literature search from past papers. I do find like some of the papers, like this is a rather old paper of in 2000, where the author actually, I mean, this paper was written for another purpose. It was meant to study the effect of some drugs on reducing the platelet aggregate size without causing bleeding. So that is the purpose of that paper. But I thought this diagram may shows quite well how deaggregations look like. Unfortunately for me, I don't have any example at hand. But so from here you can see that on this paper, right, you can see that the aggregations was the deaggregation, or sometimes we call it disaggregation, was measured as a percentage of the maximum deaggregations. So in this case, there is a experiment done, for example, in the panel A. So you can see that the EDTA was used to completely reverse the aggregation, so that is 100%. And when the different antibodies like NTP selectin, which is one of the important adhesion molecules on the platelet itself, when NTP selectin is added, the disaggregation or deaggregation happens was achieved around 95 to 100%. And then another similarly, they have, I mean, in this same experiment, they have done delayed adding of the agonist. So, I mean, I'm not trying to go outside the real questions. The real question is what is significant deaggregations, right? So for me, I think I can't find a definition for it. But if you were to describe it in the qualitative manners, and if you really want to I suppose from my point of view, my personal point of view, if we want to know what is significant, I would then look at the amount of deaggregation. Does it go beyond the so does it makes the platelet aggregation become less than your normal range? So for example, here you have less than 50%, or for example, if the cutoff is 50%. So then I would think that this might be significant. But again, there is no clinical, I think to my knowledge, there is no clinical study that can show directly percentage of aggregations with bleeding tendency. So this is maybe another dangerous way of saying, but I think if you ask me how do I define a significant deaggregation, then I would use that as a very rough gauge, as a kind of normal range. But the way that this author written is they are actually comparing with the isotype as well as the maximum deaggregations. So I mean in the normal experiment, normal platelet aggregation studies, we don't run any of this, so it will be not possible to do this. So yeah, I think that's my answer to the aggregation. I hope I know I probably have not answered completely, but I welcome anyone in the audience if you have a better definitions of how to describe the aggregations. What is the significant? What is considered significant?
So there's a second question to Dr. Nareen. So is there any clinical significance of the lag phase? And if yes, which agonist should we inspect for it? Dr. Yip.
Okay. So, yeah. Thanks again for the questions. So I have. Can you see my screen?
Yep.
Actually, I moved, but okay. So the lag phase again is same as the aggregations. You notice all the guideline doesn't say much about lag phase, and also this. I mean, it actually mention about lag phases or the aggregation, but there is no very clear guideline on what is the lag phase. But of course, the most commonly studied one is the collagen induced lag phase. But lag phase is typically due to this phosphorylation and dephosphorylation processes in the beginning of the platelet activation stage. So hence, collagen has been used in the very early study because if you have a influx, a flux of calcium concentrations in the mixture in the signaling pathway, when there is a differences in the calcium mix, then it will actually cause a more prolonged kind of lag phase before the aggregation actually occurs. Now, I don't find anything from the literature, but there is a lot of inference to say that lag phase is actually important parameter to show. So in our lab, we do report, if we observe a lag phase, we do report it, but we do not have like anything beyond a qualitative statement to say it's prolonged or it's delayed kind of activations. But in this study, I find it quite interesting. I think it's maybe a little bit like quite old study as well, where patients response to aspirin was studied in the long term on the cardiac patients in the long term. So basically the objective of this study is to show that after long term consumption of aspirin, the sensitivity towards the aspirin will start to slowly decrease sensitivity of patients to aspirin. So they actually use lag phase as one of the monitoring one of the parameter that they use to monitor. So before having aspirin, you have about 40 seconds, less than 40 seconds of lag phase. Then after at the baseline, so you had a significant delay, and then after that, across months, then the changes are slowly back to the baseline. So again, how do we use this lag phase and what is significance? I don't know any clinical study that actually point out conclusively to say that having lag phase means tendency to more prone to bleeding or not. So again I know I didn't answer completely, but I think in my opinion, lag phase is something that is very can be affected by a few pre-analytics problem, especially if you are doing it in the conventional manual methods. So I think the lag phase may be very quite a high variable kind of measurements. So if you see I don't have the raw data, but you can see the SEM, the standard errors of mean, is actually quite big. So I believe the range of the lag phase is going to be big. So if you really are interested, I would think collagen would be the one to go for. So I think there is a questions from the chat. Can someone read it out? Cannot really see. There's a question, right?
Yeah. Well, first of all, Dr. Yip, thanks for addressing Dr. Narin's question. Dr. Narin has forward this question prior to the webinar, so we also like to thank Dr. Narin for these questions. So we have a few more questions here for Dr. Yip. Give me a moment. Sorry, Dr. Yip, I know we overrun the session for a while, but there's about 3 other questions in the panel here. So the very first one here is there any reference range for ADP agonists that use concentration of 1 micromolar, 2 micromolar, 5 micromolar, and 10 micromolar?
Okay, so I think for this, I believe there is a study. I off the hand I cannot remember, but there is I think Australian from Australia. I think there is a study that actually they have done this calibrated to different using different ADP concentrations. So for our lab, we did not. We did a preliminary study. That means we just use 3 normal donors to see what is the minimum amount of or concentrations of ADP that will generate at least a 3 times aggregation response. But that was not for the purpose of establishing the range. That was to establish the threshold concentration. But I believe that I have read it, that I know that there is, But whether it was presented as a reference range, I will have to check. Maybe I will forward the paper to Sysmex organizer, so after that can probably forward for to over. I know there
Sure.
is, I have written, I have read somewhere, but I don't have it offhand. Yeah.
Then the second question here is how many minimum tests we can perform on CS 5100 for all parameters after dilution of reagents.
Minimum what?
The minimum test
Oh,
after
uh,
dilution of reagents.
I don't quite understand the question, sorry. Maybe you want to, is it the concentration of
Mm,
minimum test?
so, so I'm also not very familiar with the question
Is
here.
this about the concentration, how much like reagent vial, one reagent vial can do how many tests, or is it about the platelet rich plasma, how much is needed to do the test? Maybe I don't quite understand the questions. If it is the reagents, if it is the former one, talking about how many tests can the reagent do, I think this one I leave it to Sysmex to answer, because I think the reagent insert will have all the information. But it is about the amount of plasma that is required. Again, that is also depending on the tube that you use. So typically we draw at least two or three tubes. I would say 3 tubes to be able to complete all the 5 agonists, and that is with some buffer for repeat.
Okay. There's one question here. ADP, collagen, and ristocytin. Can it cover all aspects and the need of analysis?
Typically, sorry.
Will you be able to answer a question like this?
So 3 agonists, right? So I think minimally you need to have what was the 3 agonists mentioned?
ADP, collagen, and ristocytin.
You can answer the question that you want with that 3, provided it's nothing to do with, I mean, usually people want to investigate aspirin, they will use arachidonic acid. So it all depends on what is the study. But I know like sometimes there is a specific study if they want to look at certain response to do with some drugs, for example, they may just use this as a guide. But if you want to study congenital platelet dysfunction, then I think you need to start with at least the 5 that was recommended. So if it's for research purpose and a very specific purpose, and you only want to know the ADP response and the collagen response, because there are some other different receptors that you would not be able to characterize with these 3 agonists. Yeah.
Perhaps we can address one more last question here. We do
Yep.
receive a few more, and perhaps we can address the rest of the question offline. But for the last question for today, right, is that for Dr. Yip, can ATP release in response to collagen, be it in normal, even if the aggregation response to collagen is absent?
Okay, so that means triggers. So I believe if you are talking about, is there any measurable amounts of ADP that is being released by dense granule, by the granules with the collagens? I think there are some signaling pathway that allows some release, but I don't recall any particular concentrations. That means there is study where they actually use a very minimal, very low dose of collagen to trigger the signaling pathway, and there is ADP release, but it is not generated enough to to have a measurable response in platelet aggregometry setting. So I think you maybe need to use a more sensitive methods to study that. And also probably you need to measure the ATP itself. So unfortunately, I don't have personal experience on this, but I do read some of the experiment that they use a small amount of collagens to CRP to kickstart the signaling pathway.
All right. No, so Dr. Yip, thank you for we thank you for coming online today with us to address some of these questions, especially on the platelet aggregation
Sure.
and stuff. So we'll end the session here for today. So thank you, Dr. Yip, again, and everyone for having you all to join us today